like to call this Prepping for PALS. I'm Dusty Lynn from the Life Support Learning Center. I'm the pediatric educator there, and this is some online education. We also have a more in-depth basic dysrhythmias as well as advanced dysrhythmias for pediatrics. If you'd like to join us for classes when we can get those going again, we'd love to have you. This is an overview of what we talk about there in much greater detail. So pediatric dysrhythmias, we're going to talk about the three main categories of dysrhythmias in the pediatric patient as defined by the American Heart Association. These are exactly the same rhythms that we talk about and review in PALS, so this will help you with that as well. It is very important to distinguish between what is stable and what is unstable in a pediatric dysrhythmia. So that is over and above what we are talking about here, but keep that in mind. It's very important. We will touch on it some, and again in our full course that we do at the Life Support Learning Center, we talk about that in greater detail. But for now, it's very important to look at each patient as an individual and what is normal for this child as opposed to what is abnormal. For example, if you have a 5-year-old whose baseline heart rate is 100, when he's asleep it may drop down to 70. If he's running around or if he's agitated, it may go to 150. But if he's sleeping and his heart rate is 150, is that normal? Of course not. So again, understanding what's normal and what's not normal, and then what is stable and what is unstable is very important. It really is all about perfusion. What is their cardiac output? How are they maintaining? What is their mental status? If they have altered mental status or decreased level of consciousness or decrease in their SATs or a decrease in their end-tidal, meaning they are in a low cardiac output situation, certainly if they're agonally breathing, then all of these are depicting a very unstable patient, and whatever the rhythm is, we need to take care of it right away. In simpler terms, in a pediatric patient, they have very few goals in life. They need to breathe easily. They need to eat and eat well. They need to pee, have good good urine output, and they need to rest and sleep well, which all allows them to grow. We'll briefly review a normal variant that you might see in your pediatric patient is sinus arrhythmia. If you watch their rhythm strip, you will see that it gets faster and then slower. All the beats look the same. It's very much a sinus rhythm. It just goes faster and then slower when they're not really doing any activity. But if you watch closely, you will see that when they take a deep breath in, that their heart rate increases. And then when they exhale out, it decreases. And that's a very normal variant in the pediatric patient. So that in and of itself is not a alarming arrhythmia. So let's talk about rhythm groups classified by their pulses. This is exactly how we go over it in PALS, and that's what we're going to do today. So too fast, the pulse is too slow, or you go to check a pulse and it's not there. Tachydysrhythmias, Bradydysrhythmias, or pulseless arrest. So let's talk about the rhythms that are too fast. And again, these are in pulse groups, so we're talking about patients who have a pulse. Sinus tachycardia in and of itself is not a cardiac rhythm disturbance. You might see profound sinus tachycardia, but when you see that, you're not thinking, oh, we got to get a cardiac consult. You may be thinking, is he febrile? Is he dry? Is he in pain? And sometimes just increased activity will be sinus tachycardia. If they're unstable, it's not because of the rhythm, it's because of the underlying issue that's making them have an increase in their heart rate, sinus tachycardia. So let's talk about true cardiac dysrhythmias, tachydysrhythmias. So tachydysrhythmias that we're going to talk about today really are going to be SVT and ventricular tachycardia. Again, in our full class that we do pediatric dysrhythmias, we will talk more about other dysrhythmias. But today we're going to talk about SVT and ventricular tachycardia. These are the main rhythms that you will see in a PALS class. So supraventricular tachycardia is really an umbrella title, because anything that's causing tachycardia that's not coming from the SA node but is above the ventricles could technically be called SVT. So you might hear that different dysrhythmias, atrial tachycardias, ectopic atrial tachycardia, atrial fib, flutter. Strictly speaking, these are all considered SVT, supraventricular tachycardia. But for the purposes of PALS and for the purposes of this brief overview, we are going to talk about SVT as a re-entry mechanism, more likely to see that in the pediatric patient. So supraventricular tachycardia, as opposed to normal sinus rhythm, if you can see, the drawing depicts that in SVT there's an accessory pathway located somewhere in the atrium that is actually initiating the rhythm. It is too fast for the SA node to be generating this rhythm, and it's narrow, so it's not coming from the ventricles. So the rate is over 220 in an infant, over 180 in a child. And for the purposes of this presentation, as well as PALS, an infant is a baby from newborn until 1 year. After they turn 1 year, they are considered a child. So if their resting heart rate is over 220 in an infant or over 180 in a child, that's a huge red flag, and you need to get more information. You need to put them on a monitor and look at their ECG, look at their QRS. Is it narrow? Is it less than 0.09? Is it regular? You may or may not see P waves. It could be episodic, meaning PSVT, where it's a normal sinus rhythm and then it flips into SVT and then it flips back out. And episodic could again be PSVT. But more than likely, that's supraventricular tachycardia, the re-entry mechanism from an accessory pathway. Lots of different reasons why they can have this, but again, at the bedside, you probably won't be able to tell if it's an AV-RT or AV-NRT, and again, that's discussed in deeper discussion in our basic dysrhythmias class. For the purposes of today, we're just going to talk about SVT as a re-entry mechanism, because at the bedside, you're often treating them the same. The main thing you need to decide, are they stable or unstable? Stable for the purposes of PALS and for the purposes of this presentation is their cardiac output is okay. They're perfusing their brain, they could be fussy, they could have normal level of consciousness, but all in all, they are stable because they have enough cardiac output to the brain. However, if their cardiac output is compromised and they have an altered mental status, decreased level of consciousness, they could have signs and symptoms of congestive heart failure. They're wet breath sounds and working hard to breathe. They could have poor perfusion leading to hypotension. This depicts a very unstable patient, and you need to do something right away. So what do you do in the stable patient in SVT? Again, in pediatrics, we're going to put them on a monitor. We may, depending on where we're treating this patient, we may start an IV. The reason why I have a question mark there is because, in general, pediatric patients can tolerate SVT rather well. If you are an EMS crew and you are out and it's a incidental finding that this child is in SVT, you may notice that he is stable, he's fussy, he's crying. If you go to start an IV, that might alone break his SVT. If you're not successful in his IV, then you have to make a decision. Are you going to try again? And, mom's going to be asking, okay, so you didn't get the IV. Now her baby's crying and screaming and she's trying to calm him down and you want to stick him again. And then you may decide, you know what, we'll just take him into the ER. He looks good. He's stable. We're going to let them take care of this. And then she may question, well, why did you stick him the first time? Are your skills just not up? It just puts you in an unusual position. So in general, if I see stable SVT in the pediatric patient on an EMS call, I'm just going to keep him happy and bring him in. If you're in an office somewhere, you may decide to go ahead and transport him. I would go ahead and transport him ALS, just because even though he's rock solid stable now, you want to make sure that they're monitoring him. You certainly can call for a cardiology consult and do a 12 lead even. You can try some vagals. And vagals, for pediatrics, it depends on whether or not they can follow commands. Oftentimes, vagals are more diagnostic than therapeutic in that they will break the SVT, but oftentimes it comes back. So just be prepared for that. But if they're stable, it's okay. You have more time to decide what you're going to do. And you can also give adenosine in the stable supraventricular tachycardia pediatric patient. And just beware that if you're going to do that, you got to start an IV, clearly. And again, that might break the SVT. Baby's going to cry, calm him down, etc. If this is an infant, you might want to let mom know, we're going to give him this medication. It doesn't last long, but it might make him look a little funny or strange. Prepare her, because when he goes flaccid for that few seconds and then comes back up, he may scream, he may be very agitated, and that's very unnerving to a parent if they're not warned that. Likewise, if this is an older child and he's aware of his surroundings, and clearly if he's stable, he's going to be. When you give him that adenosine, you might say, Johnny, hold mama's hand because this is going to make you feel funny. It won't last very long. It'll be very quick. But just let him know what's coming, because it is very unnerving if you don't. So let's talk briefly about adenosine. So adenosine must be administered quickly. It has a half-life of maybe 9 seconds on a good day. And so you want to start a line closest to the heart that you can. You need a flush big enough to get it from wherever the point of entry is to the central circulation. And in doing that, you're moving hard and fast. You want to make very, very sure that this is an absolute airless setup. If there's any air in your setup at all and you go to slam this medication in and then slam saline behind it, you can cause an air embolism into your patient. When it goes into that right atrium and goes through the tricuspid valve, into the right ventricle, through the pulmonic valve, up into the lungs, if there's air in there, you can cause a air embolism. And it can be worse. If you have a patient who has an open atrium, they have an ASD or a PFO, patent foramen ovale, when you go to push that IV adenosine in, because you're pushing so hard and fast, you're transiently changing the intra-atrial pressures of the heart. And if there's any air in there, you can blow open that PFO or just shoot across that ASD. And if there's any air in there, you can cause a right to left shunt, and that air can go right up into their brain. So again, it's the only drug on the pharmacopoeia you slam in because of the half-life, and so you really want to make sure that it's an airless setup. And that is the treatment of choice in the unstable SVT pediatric patient is adenosine. The other treatment that you can do is synchronized cardioversion, and you make your choice based on how critically unstable the patient is and how quick you can deliver therapy. So if he already has an IV in, then of course adenosine is the way to go. If he doesn't have a line, if you can't start one quickly, if he's that unstable, if the adenosine is not right there, you may have to synchronize cardiovert him. And just make sure that you know exactly what mode you're in, how many joules you have, and on what waveform you are highlighting before you synchronize cardiovert every single time. So again, adenosine, treatment of choice, and so long as there's not a delay in the unstable patient. Okay, so let's talk about ventricular tachycardia with a pulse. The main take-home message here is this is very rare in the pediatric patient. If you have a patient who presents in ventricular tachycardia with a pulse, you must understand and get to the reason why very rapidly. Because if this is, for instance, a toxidrome, how you treat it is going to be different. And kids won't, if they happen to be stable, they won't stay stable long. So you really need to figure out why they're in ventricular tachycardia. Sometimes when you think about a new onset of a dysrhythmia in a pediatric patient who is hospitalized, you have to think about iatrogenic issues. Does he have a central line? Has it migrated? Is he on ECMO, or his cannula is in the wrong place? Is there something that we have done or that he has that is causing this new onset ventricular tachycardia? So monomorphic ventricular tachycardia just means that it's coming from one irritable site in the ventricles. And when you look at it on the screen, it all looks the same. All the beats look the same. Ventricular tachycardia with a pulse, the QRS is going to be wide. If the patient is stable, again, that's very rare, but be prepared for the worst and go ahead and get an expert consult. You may want to do a 12 lead. Some will get an echocardiogram. You may be asked to do a pharmacologic conversion on this patient and give him a loading dose of amiodarone. And if that is the case, just remember he needs to be very well monitored. This child is going to be a one-on-one. You're probably going to load him with half, maybe 2.5 of amiodarone over 30 minutes, and then the other 2.5 over the other 30 minutes for an hour load, whatever the discussion is. But just know that even though he is stable at the moment, once you give him that amiodarone, he could become unstable if it's given too quickly. So you really want to be have him monitored very, very well. If he is rock solid stable, he's not a cardiac patient. This is not an ingestion. You have absolutely no idea why in the world this pediatric patient is in this wide complex tachycardia that is monomorphic and he's stable. Someone may say, try some adenosine, and that's okay. That might discover that he has a aberrantly conducted SVT and adenosine. If it works, that's what it is. It's not ventricular tachycardia, and that oftentimes is tried before other things, and that's okay. If, however, this pediatric patient has VTAC with a pulse and they're unstable, they're in and out of consciousness, they have a decreased altered mental decreased or altered mental status, they have hemodynamically unstable vital signs, you may need to synchronize cardiovert them right away, which is the treatment of choice in the unstable ventricular tachycardia with a pulse. We would synchronize cardiovert at 0.5 to 1 joule per kilo. We have to, again, be thinking, what is the cause of this ventricular tachycardia, as the treatment might vary if it's a toxidrome, or certainly if it's a migration of a line or such. So you will notice the difference between monomorphic, where it all looks the same, it's coming from one foci in the heart, or polymorphic, where it's coming from many different places in the heart, and both being in the ventricles. Very, very important to differentiate between the two because the treatment is different. In monomorphic, we said if they're stable, we have time, we're calling cardiology, we're getting an EKG, you might try adenosine, you put them on a monitor, you're getting ready for the worst, you may load them with amiodarone. Polymorphic, wide complex tachycardia is treated totally different. And like adults, when you see that, the first thing you think about is magnesium. In polymorphic ventricular tachycardia, the mechanism is often something that has caused a prolonged QT. That is very important to note and differentiate, because amiodarone, the treatment for monomorphic ventricular tachycardia, actually works. It's a potassium efflux blockade, and it actually works by prolonging the QT, and it has a very, very long half-life. And the last thing you want to do in a polymorphic wide complex tachycardia, or torsades in the example that you see, would be to give something that would prolong the QT. So polymorphic ventricular tachycardia might be congenital. They've had it since they were born and didn't know it. It could be caused by a toxidrome, and notice which toxidromes are on the screen. Therefore, of course, you would not want to give amiodarone. So the treatment really take care of the ABCs like any other patient, and you're going to give magnesium. And if you have to use electricity and they still have a pulse, because the pulse will kind of come and go, oftentimes if we're using electricity and they have a pulse and it's polymorphic wide complex tachycardia, we're often going to use it in the defib mode, even though they have a pulse, because it is intermittent, and that's like trying to corral cats into setting the electricity where it needs to be. So this is the one exception of using electricity with someone with a pulse and it not being in the sync mode. You will see the reference there to Credible Meds. It's just one of the several different apps that you can get that will show you different medications and different over-the-counter medications as well that can prolong the QT. It's very important to have a quick reference to understand, because there's a lot of drugs and medications out there that can prolong the QT, and taken in combination, that might be why your patient presents in a wide complex polymorphic ventricular tachycardia. So now we're going to talk about the rhythms that are too slow. The main point here is to recognize that almost all pediatric patients who become bradycardic do so because of airway, breathing, circulation issues. It's either a respiratory issue that's gone on too long, or a shock issue that's gone on too long, and now they've become bradycardic. So understanding that and understanding your treatment is taking care of the ABCs, and you almost always take care of the bradycardia. So your rhythms in your bradycardic patient could be a primary bradycardia or a secondary bradycardia. And as just mentioned, almost all bradycardias in the pediatric patient are secondary, meaning they're from something else. So take care of the airway, take care of the hypoventilation, and you'll take care of the bradycardia. However, there are some pediatric patients, and they're rare in the general population. Certainly in the hospital population, they're not as rare, but they could be a primary bradycardia, meaning they have congenital heart disease. A lot of those kids are set up for bradycardias for many different reasons. They can also have acquired heart disease. Acquired heart disease is often like a virus that's gone on so long that it actually attacks the heart as well, the myocardium. The last couple of children that I put on ECMO were 6-year-olds, both of them, who ended up getting viral myocarditis. And one child, the day before presentation, he would walk up the stairs and have to sit down and take a breath because he was working so hard to breathe. He had dyspnea. The other child, the day of admission, it's in the summertime, and his mom found him sitting in front of a fan just trying to get a deep breath in. He was trying to PEEP himself, and that's acquired heart disease, myocarditis, cardiomyopathy. Both of these and other different acquired heart disease can cause bradycardia in the pediatric patient. The important thing, again, to know, all of them require good airway, ventilation, and oxygenation control. If that doesn't turn around their bradycardia immediately, you may need to start CPR. If this is a primary bradycardia, especially congenital heart disease, you're going to think about pacing early on. But for most of your children who have secondary bradycardia, again, take care of the oxygenation, ventilation, and the perfusion, and that will oftentimes take care of the bradycardia. If it does not, you're going to start CPR, and the first drug of choice is going to be epinephrine. So in the unstable bradydysrhythmias, decreased cardiac output, they could have a sudden collapse, hypotension, all these things depict a very unstable patient. Your initial treatment for all your patients, adequate oxygenation and ventilation. If your patient remains stable and if your patient remains unstable and his heart rate is less than 60, we've oxygenated and ventilated. If his heart rate doesn't immediately come up, and I'm talking a couple of breaths, we're going to have to start CPR. And you start CPR, again, for poor perfusion, heart rate less than 60 that does not turn around with oxygenation and ventilation. Your first drug of choice is epinephrine. We'll talk briefly about first-degree heart block. We will talk about heart blocks in greater detail in our Pediatric Basic Dysrhythmia class on the Life Support Learning Center website. But for now, just know that first-degree heart block is usually no big deal. It just means that the PR interval is over 0.20, over 0.18 in the infant, And it usually, there's a lot of kids who have a first-degree heart block, and it's no big deal. If, however, this patient presents as a possible ingestion, or he's on medications that could be cardiotoxic, it is a huge red flag, because what is a first degree can turn into a second degree and lead to a third degree heart block. So always very important to note it, a first degree, and not just blow it off, and make sure they're not in a high-risk group. For kids with congenital heart disease, again, and they're bradycardic, you think of pacing early on. Oftentimes, you may need to try atropine as opposed to epinephrine. In a case of myocarditis, when you think of itis, you think of irritation, inflammation, and epinephrine in those patients could set them off into VTAC, ventricular tachycardia. So sometimes you'll see us use atropine for patients with congenital heart disease who are in bradycardic rhythms, but otherwise we often will pace them early on. Now let's talk about pulseless rhythms. A pulseless arrest, you basically have three types: asystole, pulseless electrical activity, VFib, or pulseless VTAC. Two major types of treatment: it's either shockable or it's not. Two main etiologies of pulseless arrest are the asphyxial arrest. Again, it's respiratory failure that's gone too long, hypotension or hypotensive shock that's gone too long. Both of these can lead to cardiopulmonary failure. That is when the compensatory mechanisms have failed, and now these patients are bradycardic and they're gasping, and if we don't intervene right away, they are going to go into pulseless arrest. You can also have sudden cardiac arrest. And when you have any person, any age, who is totally fine 1 minute and then down and pulseless the next, you always have to think about a cardiac etiology. Let's briefly talk about CPR, because all these patients are going to require, at least initially, CPR. And it's very, very important that we are doing a good job. Over the years, every time ILCOR comes out with their recommendations with CPR, it's almost always improve it. And so we need to have a secondary, at least secondary confirmation that we're giving high quality CPR anytime we are trying to externally distribute blood flow through a patient's body. So how do we do that? Initially, you may walk in a room and see a patient who is gasping and unresponsive. You check a pulse, there's no pulse. You call for help and you start CPR. You're doing high quality CPR, and when the first person comes in, they may start bagging for you. The second person that comes in, they may be getting the monitor and defib for you. The third person that comes in, they may be getting ready to get a line and meds. As soon as you have enough people, you need to have someone put their hands on that brachial pulse and make sure that as you're doing chest compressions, you feel blood moving through that vessel. As soon as you can put them on capnography, that's the end all to whether or not we're doing high quality CPR, and that should be 15 to 20 in the pediatric patient. When you are giving adequate CPR, your end-tidal number should be 15 to 20. You might have an arterial line, and you'll notice you see a nice whip in the arterial line, meaning that that's a radial art line. Every time you do compressions, it's detecting blood flow. That's good CPR. So always verify that you're giving high quality CPR. Another very good thing, we used to do this all the time in resuscitations, is as soon as you have enough hands on, you're giving good CPR, you have someone pick up a stethoscope and just quickly listen to bilateral breath sounds as you are bagging the patient. Because again, you're going to rule out PEA from a source of a tension pneumothorax right away, and it's just good resuscitation to know you have adequate bilateral breath sounds when you're ventilating a patient. So the first line drug of choice in all these rhythms that are pulseless is epinephrine. Asystole, you treat with high quality CPR as evidenced by capnography Again, arterial line, a good compression pulse, high quality CPR, and epinephrine. PEA, if your patient doesn't have a pulse and you put them on a monitor and you see any kind of rhythm that looks like it should be an organized rhythm and should have a pulse but doesn't, that's PEA. PEA is a syndrome, not a particular rhythm. So if it looks wide, then of course you would consider it ventricular. But other than that, a pulseless electrical activity could look like sinus tach, sinus brady, sinus rhythm, high quality CPR, epinephrine, and you have to treat the cause. You have to think of what could be the etiology of this dysrhythmia. And again, if you've listened to bilateral breath sound, you've already ruled out a tension pneumothorax, which is way down there on the list by the time we think about it, and yet that's something that's very reversible, and we would want to take care of early on. If the patient is in ventricular fibrillation, the answer for VFib is defib. They could also be in a pulseless VTach. A little bit about defibrillation safety here is when you are in charge of the monitor defibrillator, you should always have your eyes on the patient when you are pushing the shock button. Stuff can happen in nanoseconds when you've looked and you're clearing and then you turn back and look at your monitor. If your eyes aren't on that patient, someone come in, a parent, attending, anyone can come up and we just automatically put our hands on a patient. That's what we do. And you could lose your whole team. So a little exaggeration there, but you need to be very careful. So when you are pushing that shock button, your eyes should be on your patient, not on the monitor. So pulseless VFib, pulseless VTach, or ventricular fibrillation, again, the heart's not pumping at all. You're doing CPR until you're ready to shock them. And as soon as you're ready to shock them, you don't continue your cycle. You get right on the chest with electricity. That's what they need. So the answer for VFib is defib. And follow your algorithm. But basically, the main point here is if this is pulseless VTach, and you've started CPR, and as soon as you're ready to defib, you defibbed, and you shock them. As soon as you shock them, you get back on the chest, doesn't matter what's on the screen. After 2 minutes of high-quality CPR, you're going to look on the screen. If it's in VFib, you're going to rock on and go ahead and shock them again. And again, 2 more minutes of CPR. And now in your algorithm, after your 2 shocks and 2 minutes of CPR, it's time for epinephrine. And oftentimes in the pediatric patient, if they are pulseless, as soon as the epi's ready, we will say, here's your epi, it's ready, and we'll give it. And that's totally fine in the pediatric patient. We wouldn't do that in the adult algorithm for VFib, but in pediatrics, we oftentimes do that. But just remember that if they're in pulseless VTach, before you give epinephrine, you have to ensure that they're still pulseless, because sometimes ROSC, return to spontaneous circulation, may mean that they now have a pulse with VTach and they're no longer pulseless. So before you give epinephrine, you need to make sure that they're indeed still pulseless. If you have them on capnography, you'll know this right away, because what was 15 to 20 showing that we have good CPR in progress may be where it rises suddenly to 50, 60, sometimes even higher. And then as we're doing CPR, it's going to be dropping and ventilating. It's going to drop down to normal, 35 to 45. That's ROSC. And you know you wouldn't give epinephrine for that if they're in VTach. So just always verify that before you give epinephrine in the pulseless VTach patient, that they are indeed pulseless before you give that epinephrine. So in summary, our overview of pediatric dysrhythmias, we're going to base on pulse groups. They're too fast, too slow, or they're pulseless. And our 2 fast rhythms, the main ones we're talking about today, was SVT and ventricular tachycardia with a pulse. Very important to determine if they're stable or unstable in all of the dysrhythmias. And certainly if they're pulseless and you're given CPR, you need to verify that you have high quality CPR in progress. The first line drug of choice in all your pulseless rhythms is epinephrine. Thank you for listening. and I hope you'll join us for our full pediatric classes as noted on the Life Support Learning Center website. Thank you.